Hi everyone, welcome to Surgery Dada. So today we shall be discussing a very small and interesting case, and the case is a Wilkie's syndrome. So what do we mean by a Wilkie's syndrome? The another name for this syndrome is cast syndrome. What do you mean by cast syndrome or Wilkie's syndrome? Let us understand. So Wilkie's syndrome, or it is also known as cast syndrome. The first thing that we need to understand is all these things are associated with just one fact: altered aortomesenteric angle. So let us try to understand and explore each and everything. So when we talk about Wilkie syndrome or cast syndrome, it is defined as nothing but compression of the third part of the duodenum, compression of the third part of duodenum in between the superior mesenteric artery and aorta. This is what is very important. And why this compression happens? Because actually if you see, this is the normal route of the duodenum, that it is lying in between the SMA and the aorta. The answer is due to decrease, and this is abnormal decrease. So this is abnormal decrease in aortomesenteric angle. Now this is what is very important. When we talk about a conventional aorto angle or aortomesenteric angle, what is that? So this is very important, that if you talk about the aorta and this is the superior mesenteric artery, so this angle, this is what is known as the conventional aortomesenteric angle, and the normal value is somewhere from 45 degrees up to 60 degree. Students, there are books who report 38 degree to 60 degree also. This is what is very important. The range is, the average value is roughly around 48 degrees, and the range is from the 38 to 60 degrees. Do you know, if the angle falls below 30 degree, this is what is very important, this is considered to be a narrow aortomesenteric angle. And if it goes below 25 degree, this is associated with compression of the third part of the duodenum. This is what is very important. And when you have the compression of third part of the duodenum, then you have something which is known as what, students? Wilkie's syndrome. This is what is very important. Or another name for this is superior mesenteric artery syndrome. So we have Wilkie's syndrome, cast syndrome, or superior mesenteric artery syndrome associated with decrease, abnormal decrease in the aortomesenteric angle. Now when we are talking about evaluation of this, what are the important things that we need to understand in Wilkie's syndrome? Let us see all these things. Who is at risk? What is the presentation? Let us understand. So when we talk about the risk factor, the first very important thing is, it is the gender, and females. It is very common in young females. This is what is very important. Why? Because young aesthetic female, this is the word that is used, young aesthetic. Now aesthetics or aesthesis, this is basically subjective. Some people like me who are fat and obese, they are also happy, but there are some lean and thin, they always think that they are more and more obese, and they keep on losing weight. And this phenomena, I hope you know, this is what is known as a neuropsychiatric condition like anorexia nervosa. So remember, this is what is again very important. So young aesthetic females, patients who are not, you can say, psychiatrically stable, so anorexia nervosa. Then patient with prolonged immobilization, so prolonged supine immobilization, this is again very important. So prolonged supine immobilization. One more thing is cast. So cast, and what kind of cast? Abdominal cast. Then students, post total proctocolectomy, when we talk about the iliorectal or ilioanal J-shaped anastomosis, so this is what is very important. Remember, post total proctocolectomy, whenever we do this with J shape, it is ilioanal anastomosis. They are also at risk of this. Again, students, any patient who has rapid weight loss, he or she is at risk. Then students, scoliosis is again a risk factor, etc. There are lot of other factors also. So remember, these are the standard risk factors that we have When it comes to presentation, what is the classical presentation, students? Intractable epigastric postprandial pain with vomiting. This is what is very, 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 very important. So when we talk about the classical presentation, the epigastric abdominal pain, this is what is very, very, very important. So abdominal pain, then this is postprandial, this is what is very important. So postprandial increase in nausea, and not only this, there is vomiting. So this is what is very important. So epigastric pain, postprandial nausea and vomiting, and along with that pain, and that is why patient develops aversion to food, and this is what is very, very, very important. So weight loss, and why weight loss? Because of something which is known as cetophobia. So this patient develops a phenomena that whenever I eat food, the pain starts, so I will not eat, and this is what is the reason for further worsening of the condition. Try to see, students, I will show you the image. This is a classical, you can see this is a classical image where I will be showing you the concept of aortomesenteric angle. So this is the normal, you can say aorta, this is the superior mesenteric artery. So you can see this is the superior mesenteric artery and this is aorta, and between this is the duodenum which is present here. So because of the narrowing of the angle, what will happen, students? There will be compression. So if you see in this image, the angle that they have shown is 21 degree. I will add this image to the, you can say, to the notes also, and this is what is very, very, very important for you, because I will also tell you about the distance. So let me add it here for you. So when we talk about the symptoms, why the symptoms happen? The symptoms happen because of the compression, and this is what is very important. So can you see, reduce aortomesenteric angle is the reason, and the angle less than 25 degree, or aortomesenteric distance is also one very, very, very important, less than 6 mm. This is what is very important. Normally it is more than 10 to 12 mm. Students, patient may experience the symptoms with the aortomesenteric angle or with an aortomesenteric distance as low as 8 mm also. Now let us talk about the evaluation. So when we are talking about evaluation, what is the investigation of choice? Answer is, we are going to go for upper GI barium or gastrographin. Basically we prefer gastrographin. So upper GI gastrographin series, this is what is very, 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 very important. On upper GI gastrographin series, what you will come to know, non-passage of contrast across the third part of the duodenum, with the distension of the proximal pouch. This is what is very, very, very important. What are the other investigations? CT angiography. This is what is very, very, very important. So abdominal CT angiography is again the important investigation. So investigation of choice, generally we have the upper GI barium or upper GI gastrographin. We actually prefer hypotonic agents so that the edema is not there. So CT, if you take a hypertonic, the abdominal, you can say, content the barium, or suppose if you are not using hypotonic agents, it will withdraw the water from the enterocytes and will cause and precipitate more severe pain. So this is what is the conventional you can say thing that we have. Now what is the treatment? Try to understand the first line management. The first line management is always and always conservative. This is what is important. So the first line management is conservative. The next thing that we need to understand is, if this fails, then we have to plan for surgery. What is the surgery that we have? So you cannot suppose this is the bifurcation that you are having. So this is how the things are. You cannot cut the SMA. This is what is very, very, very important. So what we are going to do? We are going to do a duodenostomy. So duodenostomy, this is one thing, or you can go for duodenojejunostomy. So end to side to side, this is what is preferred. Or students, or you can also go for gastrojejunostomy. This is one very important thing. Do you know some people don't advocate resection? They say that okay, I have a solution to this, try to understand this. So they say that okay, buddy, this is the scenario, this is the duodenum which is present like this, yeah, and since the pad of fat has been lost, that is why it is getting compressed. So this is the ligament of Treats. Now this is what is very, very, very important. So if I divide the ligament of Treats, you can further mobilize. So mobilization of the duodenum, mobilization of the duodenum with derotation, and how do you do this? By division of ligament of Treats. So when you go for division of ligament of Treats, you divide it, and this is what is known as Strong's procedure. So students, what will happen in this case? If you see, the duodenum will come down and you don't have to worry about this. So derotation of the duodenum by dividing the ligament of Treats, this is what is known as a Strong's procedure. So this is very, very, very important topic. Lot of you don't know. Most of you think that if you have a patient of this, you can say Wilkie syndrome or SMA syndrome, surgery is the first line management. No, student, surgery is not the first line management. So what is that? Conservative, it fails, then only the surgery is done.